Tato, Bruce Arroll's my name, and I'm a professor in the Department of General Practice and Primary Healthcare at the University of Auckland. This is an extended version of a talk I gave at the College of GPs conference in 2023. The title is Depression and Anxiety, or Distress, which is my preferred term, and then the rapid assessment and effective treatment in primary care. My mantra would be talk first, prescribe later, label rarely. So let's say you're in primary care and you see a 45-year-old man. He comes in and says he's not sleeping very well. What's the next best question? Well, could be anything, but what's your energy level like? I've got low energy. Perhaps the next question might be not enjoying things, work, friends, or family. So what's the next best question? And I would say at this point, the pretest probability, i.e. the prevalence or likelihood of a low mood, is fairly high. So I would ask the emotional quality of life score, which goes like this. What is your emotional quality of life? If 100 is perfect and 0 is worst imaginable, where are you now? From our research studies, anything 60 or less is associated with a significant mood problem compared to mood questionnaires such as the PHQ-9. So this would correlate well with the PHQ-9 greater than or equal to 10. Now, the problem with low mood in primary care is that 45 to 95% of patients come in presenting with physical symptoms or somatic symptoms. So we as the primary care clinicians need to move from that to a low mood as quickly as possible. Now, this is particularly difficult given that about 11% of people deny they have a psychological issue. So we need to get from the physical to the mental fairly quickly. The quality of life of somebody with a low mood is the same as somebody with renal dialysis or on renal dialysis, and they'll be feeling very sick. We need to stop the labeling. You noticed I don't use words like depression or anxiety unless that comes from the research. I believe in Ray Moynihan from Australia that a label should be more helpful than harmful. And that remember that when you're seeing patients, you may be seeing them on the worst day of their lives. I'd ask you just to reflect back to the worst day of your life. And if you'd gone and seen a healthcare professional and they had put a big label in your notes, such as major depressive disorder, rather than just unhappy because I'm having the worst day of my life, that will be in there till the day you die. I had a patient who had trouble getting a job with the police because she'd had treatment for low mood. I prefer the transdiagnostic terms that are used in acceptance and commitment therapy, such as stuck, distress, distress with reduced motivation, distress with reduced mood, distress with increased worrying, which is the old anxiety. For official purposes in New Zealand for work and income, you can use the term adjustment reaction, which is read code E29.00. What is the value of a diagnosis? Well, as Alan Francis said at the BMJ Overdiagnosis Conference in 2018, that you're often seeing on the worst day of their life. And with more visits and more time per visit, the diagnosis will disappear. A wrong label can be damning and harmful in his terms. He does say that labels can be good. For example, panic disorder. So the 20-year-old who keeps turning up to the emergency department with crushing central chest pain needs to have an anxiety assessment because they're probably having a panic attack. 20-year-olds very rarely have heart attacks unless they've got a horrendous lipid history in their family. And that's sort of a horrendous lipid history would be people having heart attacks in their teen years. So that's the sort of thing. So if somebody had a family member with that, you'd want to do a chest X-ray, an ECG, and troponins. Another diagnosis might be bipolar disorder, because people with bipolar disorder can destroy their reputation fairly quickly if they don't get their symptoms under control. So what's the value of a diagnosis? In the last few years, I've had to have 2 patients get a diagnosis on them. One of them was a woman in her late 20s, and she was cutting, and she was very hypervigilant. She has a university degree, and she does have some good jobs, but I was starting to wonder whether she may have some borderline features or PTSD. And when the psychiatrist saw her, he decided she had PTSD. A man in his late 40s who was paranoid with low mood. He had a brother with schizophrenia, although he'd been, the patient himself had been working up to age 46 years. I wondered if he was schizoaffective, but the psychiatrist thought that he had social anxiety and major depressive disorder combination. And we actually treated him with amitriptyline because he hadn't got any better on SSRIs. Interestingly, the tricyclics are probably more effective than SSRIs, but we don't use them because of the suicide potential. Depression is common in primary care. In men 18 to 24, it's 22.6%. In women, it's 33.9%. And it gets less with age. So we tend to think of older people as being depressed and lonely. On average, they are less depressed. The peak of depression in our community is in the 18 to 24-year-olds. And this comes from the Magpie study, which is now 20 years old, and it really hasn't been repeated in any society. This is anxiety in primary care, and again, exactly the same picture. Women higher than men and decreasing with age. So 18 to 24 is the peak. So anxiety is very, very high in women, less so in men, and there are various explanations for this. It may be partly hormonal, and if you take a feminist perspective, you could apply that as a view of women and their situation in modern society. These are based on 12-month prevalences, by the way. And this is the overlap of depression, anxiety, and substance use. And I think one of the take-home issues from here, take-home measures from this, is that there's quite a strong overlap between depression and anxiety, a huge overlap of some symptoms and substance use. And the take-home message there is you always have to check for substance use in your patients. Alcohol is the first port of call in many societies. It certainly is in New Zealand. And people may be social drinkers when their mood is, or worrying is good, but once their mood and worrying increases, then their substance use will increase. And this is a study from, or a paper from a psychopharmacology book. As you can see there, there's a great deal of common symptoms: fear, apprehensions, GI symptoms, sleep issues, worry, fatigue, and low energy and agitation. So they're very common, and concentration difficulty. But anxiety has excessive worry, hypervigilance, agoraphobia, compulsive behaviors, ritualistic behaviors, and I've added here helplessness and going crazy. So people who've got anxiety think they're going crazy. So when the patient says, I think I'm going crazy, you could say, well, that's good to hear, because you almost certainly are not crazy when you think that. People who are truly crazy, by what I mean is psychotic, don't usually have that insight. Over here we have low mood, loss of pleasure or interest, weight change, motivation could be down, suicidal ideation here, and there's a feeling of hopelessness. I've added the words in red there. Treatments are the same. The medication is essentially the same. Alprazolam is technically used for anxiety, although it's not the first choice because of addiction, but it also is very effective for depression. and it's generally not used these days because of its addictive potential. The talk therapies are essentially the same. So CBT, ACT, problem solving, and behavioral activation are all treatments that can be used for so-called depression and anxiety. And when they work, both the depression and the anxiety get better. Measuring mood in primary care. So I am, of course, interested in the EMA-QoL. So remember that I want to find out what your emotional quality of life is. If 100 is perfect and 0 worst imaginable, where are you now? Any score 60 or below is associated with a low mood. This doesn't rule out some level of anxiety. It can be done in 15 seconds with no reading and no glasses. When the score is below 10, it has what's called a likelihood ratio of about 25, which means you're 25 times more likely to have a low mood than not when you have a very low score. If they're clearly distressed, but the EMA-QoL is greater than 60, then you can do a GAD-2, which is the Generalized Anxiety Disorder Questionnaire 2, or a Burns Depression Inventory for today, which I'll show you shortly. This is the EMA-QoL versus the PHQ-9 from the first validation study we did. And as you can see, when you get to 65, the score drops below 10. So PHQ-9 of 10 or more is associated with a significant low mood. This is the PHQ-9, which is a very difficult question to ask over the telephone. Can you imagine trying to ask this, moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you've been moving around a lot more than usual? The patient has usually lost the plot by the time you get to the end of that, and they're not sure what you've said, and you usually have to repeat it. Over COVID, I learned to use the Burns Depression Inventory screening tool today. This is much easier. As you can see, it's only got 5 questions, and the total score is out of 20. There's also an anxiety questionnaire, which is there, again, where the total score is out of 20. So just going back to that, you can see the scoring above there, 0, 1, 2, 3, 4. And if you get a full column on the right-hand side, that's a score of 20. So I saw a woman in her early 30s. She was behvioural, which is the Maori word for European patient. She had a 5-month-old baby with a disability. It was the 3% of normal for its weight. And she wasn't able to go out because of fear of viruses. The baby would have low immunity. She had a very supportive husband. Her EMA-QoL was 60. Her Burns DEP was 3. Less than 6 is normal, but her Burns anxiety was 8, which means she has more of an anxiety picture. So this is postnatal anxiety. Very well-educated mother. Not uncommon for behvioural women who are very high functioning to get anxious postnatally. So the Burns Depression score is available in this book, Feeling Great. His earlier book was Feeling Good, but he's moved on to Feeling Great. And remember, normal for those questionnaires is 6 or less. And in this, he describes the magic button and magic dial, which is a great treatment for anxiety and works very well postnatal anxiety. So this woman had, as I say, was in her early 30s. She'd been given citalopram from a colleague 2 weeks ago and felt a little bit better. And then I said, would you be interested in doing the magic button or magic dial? And so then I next said, well, what is at stake with your worrying? Well, I want to be the best mum in the world and keep the baby safe. And on a 0 to 100 scale, her anxiety was 60 out of 100. Her worrying about things was 60 out of 100. Being tense or on edge was 60 out of 100. And being nervous was 60 out of 100. And so what I did was the magic button, magic dial. So I said, well, we could make all these things go away. The anxiety, 60 out of 100. The worrying about things, 60 out of 100. The tense or on edge, 60 out of 100. And the nervous, we could make them all go away. but these things all say something good about you. You know, you're worrying. What does that mean for your child? Well, I want to be a good mother. Why am I worrying about things? Well, I want to be a good mother. What about being tense or on edge? Well, keeping the baby safe is important. Why are you nervous? Well, I know if my baby gets a virus, it could get sick and die or get very ill. So I did magic button, magic dial. So let's say if I press this magic button, all these uncomfortable feelings can go away. Would you like to press it? And usually the patient says yes. And you said, okay, well, if you press it, you realize all the good things, your values, and those things will go away. Why? Let's just, and normally the patient, oh no, I wouldn't want that. I really care about my baby. Okay, well, I've got a magic dial over here. Can we try dialing down these feelings? And she dialed down her anxiety from 60 to 50, 60 to 50 for worrying about things, tense or on edge down to 50, nervous from 60 down to 50. And she felt a little bit better. I also referred her to the New Zealand online Just a Thought CBT to do the GAD model, which is the general anxiety disorder model. If you want to see a video of the magic dial at work, you can find it in David Burns from Feeling Great book, or you can click on this link here and watch the video demo. There's also, he has a podcast series, and podcast 159 is Live Therapy with Marilyn. What if I die without having lived a meaningful life? If you listen from minute 28 to 53, you'll see the magic button, magic dial stuff, which is pretty amazing. So this lady's dying of lung cancer, and he goes through this stuff with her. This is the act view of anxiety, is that we're pushing away difficult thoughts and emotions. It does not make them go away, but it can make things more difficult. So we have to have a different relationship to these emotions. So we may wish they're not there, but they're going to be there. The act thing about anxiety is if you don't want it, you've got it. And of course, this pushing things down, like pushing a beach ball down, only makes it come back worse. So you can hold your anxiety under your arm, and you can put it on your head. So changing the relationship to it's important. Okay, so this is the photograph of Judson Brewer, who has the most effective treatment for anxiety yet developed. And he's written a book called Unwinding Anxiety. And what he does is, and when people do anxiety, there's the antecedent, the behavior, and the consequence, or the trigger, the response, and the outcome. And instead of doing anxiety, he gets people to do curiosity. And this really goes like this. Well, what can we learn about your symptoms? Where are you feeling this worrying? Well, I'm feeling it's in the center of my chest. Is it in the front or the back? Is it the left or the right? What does it look like? What does it sound like? What does it feel like? Does it have a smell or taste? And this has a numbers, doing this, training people to do this, has a numbers need to treat of 1.6 to resolve from GAD at 4 months. This is using the Unwinding Anxiety app, which is about $10 New Zealand for a week, for a month, or $7 a week for a year. So it's quite expensive. I had a patient come in to see me saying, she was a 35-year-old Pākehā European woman, and she said, my citalopram's not working, my anxiety's back. And her PHQ-9 was 12, so a moderate depression. Her GAD-7 was 17, which is severe anxiety picture. And that is more a function of, a picture of anxiety, if there is one. So this was her second marriage. And so just think about what the function of her anxiety might be. In her case, the function of her anxiety was her relationship with her second husband. And she had about 50 days vacation owed. So I asked her if she would take some time off. and she went away for the weekend with her husband, and they talked about things, and she came out of that saying she was completely better. Her anxiety was right back into the normal range, and her mood was better. And she said, I'd saved her marriage at one visit. So, which wasn't my intention, but you know, it's nice to get a win like that. So asking what the function of the symptoms are is quite a good thing. Why is she anxious? She's anxious because she's worried this marriage is going to go out the door like the first one did. So getting back to distress, so we need to do a brief assessment. And for this, I use the Work, Love, Play questionnaire. This is on my website, www.brucearroll.com, under Work, Love, Play. You can use it. There's no IP on it. And this takes less than 5 minutes. And it gives a snapshot of the patient or client's life. And all the avoidances and escapes are obvious. And your role is to reverse them, which is what we call behaviorally activating people. And this is getting them back in the river of life, getting them back into the operant positive reinforcements. So getting them back, seeing their friends doing things, doing exercise. So exercise, friends, sunshine, nature, and perhaps some cold water swimming. Certainly those things will get you back in the river of life, figuratively or literally, because our patients, when they're avoiding things, are not in the river of life. So this comes from Freud, who thought that love and work were important. Erik Erikson came up with Work, Love, and Play. Patty Robinson came up with Work, Love, and Play also. She's the fact developer. And then I came up with work, and I broke love up into love as in intimates, love as in friends, and love as in family, and play. And on my worksheet, I have 5 categories for work: love as in friends, love as in intimates, love as in family, love as in then play. And they have to score this on a 1 to 10 scale, 10 being great, 1 being terrible. And the score of 35 or less is associated with a low mood. Everything's shifted over to the low side. Then I asked the social questions about drugs and alcohol, violence. Is violence an issue for you or your family? Is gambling an issue for you or your family? I ask about smoking, sleep, and exercise, and trauma. With trauma, it's what traumas have you had that you feel are unresolved? I also ask them about any spiritual or religious component to their life. I ask them if they're safe at home as part of the violence question, and I ask them about their values. Sometimes I ask them about their cultural identity. They may have been born in a particular country. They may have a particular ethnic look about them. Sometimes that can be quite helpful to find out. The avoidances and escapes are clear and obvious and need reversal. So of those 5 initial questions, the love, work, love, play, which 2 are reduced? Just have a think about that. Just pause for a second and think about that. Perhaps pause the video. So is it work? Is it love as in friends, love as in intimates, love as in family, or play? Values are important to you, what's important to you in the long run, and essential to know for changing behavior. These are directions, not a goal. And usually their family is important, friends are important, health is important, perhaps work is important. So these are the 2 that came out statistically. So love as in friends, and play, and exercise. And of course, these are the 3 things you can reverse pretty quickly. Much more difficult, you can leave your work, that's not always good. Hard to leave your partner, better to sort things out with intimate partners. Love as in family, hard to leave your family. But friends you can start seeing, play you can start doing, and exercise you can start doing. And that's simple behavioral activation. So it all ties up. So this gives you a snapshot of your life. I handwrite or type it, and then I scan it into the notes. It gives me a huge amount of information, and it can be very handy to be a reminder of the patient's situation at baseline. In terms of effective treatments, behavioral activation is the most effective treatment. Around about 42% of people get better with behavioral activation. Placebo in the context of a randomized trial, around about 41%. A cognitive behavior therapy, 28 to 20%, depends on the control. Antidepressants, 25% in the very severe. A nurse phone call, 20% at 6 months. None of the drug studies go to 6 months. Antidepressants, 9% in the severe. Antidepressants, 6% in the mild to moderate. And these come from the results of multiple studies, not one study. Behavioral activation, contact a friend. If it's a woman, find out who their BFF is, best friend forever. They may have lost contact with them and the BFF may be worried that they've offended them. Of course, if you don't contact your friends, they think you've lost interest in them. Exercise. So the best narrative for exercise is that your muscle are factories, or if they know about healthcare, endocrine factories that create hope chemicals in your mind. You say to your patient, do you want to have some hope chemicals? The answer is almost always yes. And then you get them do something pleasurable. Try and avoid food, because I think food is very loaded in our communities. Something like a massage or nails if they can afford it, or even just going for a simple walk with their partner or dog or a friend. This is stuff from Pim Kalpers, just showing the numbers needed to treat for intervention. So there's behavioral activation up with the highest G value there, or life review therapy, which is a very complicated one. Third wave therapies, acceptance and commitment therapy, and cognitive behavior therapy. So this comes from his work there. Problem solving therapy, something easy to do in problem care, primary care, which we do all the time. This is whether we do it as individual, group, telephone, or guided self-help or unguided self-help. Just a thought, the online CBT in New Zealand can be used here or here. Group is very effective if you can get people in groups. Groups are very, very effective. These are the psychotherapies. So in terms of remission, only about 26% of people get remission with psychotherapies. So if your patient's not getting better, don't worry, that's par for the course. Try something else or get them to see somebody else. Care as usual is pretty low, about 12% if you do nothing. There's a 13-minute video here. I would watch this video. It talks about a patient who had a PHQ-9 score of 16, which is moderate to low mood. I do a work, love, play questionnaire. The patient cries and I ask them, if your tears were words, what would they be saying? And then I show empathy at that point. The mindful anchor, we have to expose her to her negative thoughts. We do behavioral activation, exercise, friends, and pleasurable things. And she was completely better in 1 week, which is very common, almost the norm in behavioral activation. This is the truth about drugs. This is based on graphs from the FDA. So this shows reduction in a mood score versus baseline severity. So this is very severe depression. This is a big improvement here. So this is placebo. This is drug. So as you can see, placebo is pretty good, but drug is slightly better at all levels of severity. Biggest benefit is down here. And remember, this is secondary care, so that's why they probably get bigger benefits than we get in primary care. This is something we don't think about. This is visit 1. So this patient has seen, heard, and understood. They might have a severe score. They've got a mild to moderate score, visit 2, and possibly better by visit 3. This is the natural history of low mood. And so it's a good idea not to give an antidepressant at this visit and see how they are at visit 2. If they stay down here with severe depression, they need CBT and drug therapy. This is the effect size down here, 25%. Placebo is always bigger. So we add the placebo to this effect, so that's 66%. Up here, the effect size is 9%. the effect size is 6% here. So this is mild to moderate, this is severe, this is very severe. This is the numbers need to treat: 4, 11, 16. So the harms of drugs, they medicalize the condition. The placebo is 8 to 3 times greater. The patient will credit the drug, not themselves. There's a risk of adverse effects. There's the risk of overdose. I've had patients overdose on my antidepressants. Fortunately, no one's managed to kill themselves yet. And it increases suicidality in teenagers, and they can be difficult to stop. Patients get withdrawal symptoms, the serotonin syndrome. When drugs work, they work best at the severe end of depression. How do we recognize this? Using a persisting high PHQ-9 or mood inventory. The patient not getting better, whether they've had previous episodes. About 12% of Kiwis get antidepressants, probably 3 to 4% are getting a benefit. Here's a quote from Glenn Cahoon. I'll just let you read that. I wouldn't just repeat the prescription if it was an antidepressant, but it might be for birth control or some other chronic thing. Drugs at first visit. So there's an absence of evidence about this. Very hard to do a randomized trial. But remember, the majority of patients in primary care are in the mild to moderate range, and many in the severe range at first visit will become mild to moderate. So try non-drug first. Drug only from NICE is past moderate to severe depression persisting, or lower symptoms for a duration of 2 years. So doing the mood inventory is a very good way. Or the emotional quality of life, single question, 15 seconds. So here are some of the NICE guidelines at lower levels of severity. CBT and computerized CBT or ACT. Just a Thought is the New Zealand online CBT. Exercise, including yoga and stretching, behavioral activation, problem solving, and mindfulness. So the first treatment, reverse the good things that have stopped and stop the bad things that have been started. Restart the exercise, get them to get in touch with their friends, stop their spending time in bed when they're not asleep, and try and reduce their substance use. The way I sell alcohol to people is this, because if they're drinking more than 2 drinks a day, 2 or more drinks a day, it's probably going to affect the quality of their sleep. So I say your sleep will improve if you can decrease the antidepressants. And for people who aren't seriously dependent, they can usually reverse it. And just say it's a depressant, it's making you feel worse. At the second week, I check the mood. If they're not improving, I might negotiate medication or psychology at that point. Or sometimes I'll wait to the 3rd or 4th week. But if their mood isn't improving by the 4th week, I would definitely be talking about medication or referral to psychology. The medication, I use sertraline 25 milligrams to 100 milligrams. It's okay with cardiovascular disease. It's okay in pregnancy, and it has a long half-life. So when you come to stop it, it's pretty easy to stop. I avoid paroxetine and venlafaxine. Both are difficult to stop, and venlafaxine has suicide potential. You could consider citalopram or escitalopram. There are QT issues at high dose, although there's really not much point in going to very high doses. And I've mentioned the paroxetine and venlafaxine. If the PHQ-9 weekly is not changing over 4 to 6 weeks, consider changing medication. Increasing dose, not much evidence that increasing dose helps. You could try another SSRI or consider another class. I prefer, and this is very much my approach, it's not, there's no evidence for or against this. I use bupropion 150 milligrams a day because there's no weight gain, and mirtazapine 15 milligrams. You can use 7.5 milligrams. It does help with sleep. There is a risk of weight gain, so I've put 20 kilograms on a patient with mirtazapine. And of course, that's virtually impossible to get off somebody. You might want to give up after trying the 3rd drug. because there's a 50% drop in efficacy with each drug. So each time a drug fails, you're getting down to a group of people who are not treatment sensitive. My final course of action, as I mentioned with my man earlier, is amitriptyline, 75 milligrams or below, considering referral to a mental health team for a second opinion or psychology, if it's available or the patient can afford it. Consideration of something like ketamine. It can be compounded into an oral form. I don't know how effective it is in the compounded oral form, but some oral forms have been shown to be helpful, or transcranial stimulation. Or the mental health team may even consider things like ECT should the depression be persisting and severe. So I take home messages are here: talk first and behavioral activation, prescribe later if not improving, diagnose rarely in primary care, it's really helpful, and diagnoses are more appropriate in secondary care. I remember patients in primary care often present with physical symptoms, particularly some ethnicities. Maori and Pacific patients often present with physical symptoms. Very rarely do they present saying, I think I'm depressed, I'd like an antidepressant. Second visit, usually some improvement. Avoid drugs at the first visit, talk first. Remember, patients want to be seen, heard, and understood. There's a big placebo response with the drugs. And if the patient thinks the drug stopped working, then the first response was pretty well placebo, almost certainly. Use the telephone, either with your nurses or staff or yourself or health coaches. Talk first, prescribe later, label rarely. And just remember, empowering patients with low mood is very satisfying. Thank you.